This is part of my series on randomized control trials, and this one's going to talk about how to handle noncompliance. So when we assign a treatment to participants, it's possible that they might not stick to that treatment. They might stop taking it, or they might switch to the other treatment arm. The example that I'm going to be using in this video is an exercise program, so the people assigned to the exercise group would be maybe going through intense bouts of exercise like on a daily basis. Well, the control group would not be doing that. Someone in the exercise group might stop exercising, and in that sense they both stop taking the intervention and switch to the control arm. This is sometimes called contamination, in the sense that people from one arm of the study are contaminating the other arm. So it's basically a question of how do we handle this. So just kind of following that example before, we have the exercise group and the non-exercise group. This is what they were initially assigned. And 5 years later, we see that 4 people from the exercise group now aren't exercising, and 1 person from the non-exercise group is. So how do we handle that, basically? Intent to treat is the gold standard, and with intent to treat, you basically ignore that non-compliance occurred. So these 4 people that are now in the non-exercise group, we just pretend that they were always in the exercise group and that didn't happen. And same with that 1 person who switched to the exercise group. This seems counterintuitive that that's the gold standard, but basically it preserves the intent of randomization, and that'll become clear when I talk about the other option, which is per protocol. So with per protocol, we basically get rid of we don't count the data for people who switched arms. Basically, we make it a criteria for you to stay in the study that you stayed in your treatment arm. So these 4 people who switched treatment arms, their data is just deleted, basically. And now participants are essentially choosing their own treatment, and that's how an observational study works. In this setting, we're trying to do a randomized control trial where treatment is assigned, and we have basically made it so participants can choose their own treatment, because everyone who as soon as people are switching arms and we're analyzing accordingly, those who stayed in their treatment group essentially chose their treatment group, because switching treatment groups was an option, and there is now 2 distinct populations. There's those who stayed in their treatment group, they chose it, and those who did not stay in their treatment group, they did not choose it. And now all of a sudden we have these 2 populations, and the people who stayed in their treatment group and those who didn't might systematically differ in ways that are introducing bias. Because when people self-assign treatment, it can be for a variety of reasons. People who exercise and those who don't are probably different in many ways besides the fact that they exercise. So one group might make healthier decisions in just all kinds of ways. Like the exercise group, they might have a better diet, and they might just kind of live a healthier lifestyle. And since we're basically permitting an element of choice, those who remain in the exercise group might have those traits compared to those who switched from the exercise group to the non-exercise group. And in that way, we've introduced bias. So this per protocol way of doing things is also called an efficacy trial, or as treated. So it's not quite as realistic as the other option, but depending on certain settings, like if you're trying to test the efficacy of some drug or some vaccine, then that can be valuable in the sense that you really want to know how well this works in a very controlled setting. But it's not as realistic, because in reality people do switch, and we need to assess its effectiveness in the real world. The intent to treat option is more realistic of the effect a medication will have in the real world, because when you really do prescribe a medication, some people will stop taking it. And that's basically factored into our effectiveness that we end up determining how effective the medication is. Where with an efficacy trial, we might overestimate its effectiveness, because now we have this group that is strict adherers to the medication, which has really isolated the effectiveness of the medication, because now we definitely know how effective it is. But that's not necessarily an indication of how effective it will be in the real world, because in the real world, some people stop taking it, and that is part of its effectiveness. That to account for how effective it's going to be in practice, accounting for the fact that people switch, and intent to treat does that, in addition to preserving the intent of randomization. So basically, intent to treat is the better option.